monitor, or the ARM system. And these patients, these volunteers rather, were repeatedly exposed to gradually increasing levels of propofol, and then tested for their ARM responsiveness, and then tested for when they lost responsiveness to shake and shout, which is a very important clinical milestone, because then you've gone into deep sedation. You require a painful stimulus to produce an arousal response. And you can see that the ARM response loss always precedes the transition to deep sedation. So this was an important study because it showed that this device was a reliable way of detecting when a patient was starting to border on deep sedation. And that's a milestone that's critical to detect for this kind of technology. This is a look at the screenshot of the graphical user interface, the GUI. This has taken so long to approve, by the way, that this will have to be updated soon because some of these components are now starting to age because the regulatory process took so long. But it's actually a beautiful piece of work, I think. Let me just take you through some of the components. So here's the capnograph, the pulse oximeter, the ECG. This is the graph that's showing the time to respond to the auditory or tactile signal. This is the propofol infusion rate. Here's a digital readout of the response time to the ARM system, and here's a digital readout of the expired CO2. Now, there are various times in which the drug delivery can be stopped. There are red alarms that are more serious alarms, and they stop the delivery, and the alarm essentially has to be resolved so that the user can reinstate the administration of propofol. So here's a desaturation that stops the drug delivery, and the team has to clear this alarm before they can begin the delivery again. I want to take you through just very briefly, the dosing system. So here we're looking at three different things. This is the pump dose rate, and this is the predicted plasma concentration based on the Schneider kinetic model. I'm always wanting to give a shout out to my friend Dr. Schneider, since we were fellows at Stanford at the same time together, and we always get to have a little reunion at the ASA. And here's the predicted effect site concentrations that result from this drug administration scheme. So what you see is that there's a loading dose. This loading dose is automatically calculated based on the maintenance rate that is programmed into the pump by the physician. So if the physician decides it's going to be 50 mics per kilo per minute to start, then this loading dose is sort of automatically calculated to get you into that range. The loading dose is administered over 3 minutes, and then it goes down to the maintenance rate. There's also a capacity to do a PRN dose. So if the physicians are struggling with something that's a little painful, they can give a PRN dose, which in most patients is about 10 to 20 milligrams of propofol, and then they're locked out for a period of time, so they can't keep doing it. And this was put in to allow some flexibility when there are periods of inadequate sedation. And this, by the way, is one of the more controversial aspects of the technology. And there's some flexibility here in terms of how the site decides to program this PRN dosing. But anyway, this slow loading dose and these PRM doses emulate these TCI concepts. Now, what about if the physician decides to decrease the rate, or if the machine automatically decreases the rate during certain yellow alarm conditions, which are a reduced respiratory rate and a mild desaturation to below 93%, the machine will actually stop the drug delivery until the yellow alarm clears, and then it will start the drug delivery at a rate that has been linearly interpolated to be the rate that will then maintain the concentration to which the drug has fallen during the off period. Now that was a mouthful, but let me just summarize by saying it emulates TCI, okay? It's not TCI, but it's emulating TCI. So for example, if there's a brief off here because the system has got a yellow alarm, or because the docs have decided they're going to start ending the procedure and they can turn it down, then the system will turn off for a time until the drug level, the predicted drug level, even though it's not model-based, again, it's just a linear interpolation, but until the predicted level is at a point where that reaches the level that will be achieved by the new maintenance rate, and then it will kick back on. So again, it's intended to emulate TCI. I really think this is terrific because I hate to use such an enthusiastic term, but we don't have TCI in the U.S., and it was thought that that was perhaps too high a regulatory barrier to tackle. And so this was a way of grounding the infusion scheme in pharmacokinetic principles without making it TCI. So, and all of this, by the way, the dosages are all compliant with the Propofol label. So again, the dosage scheme emulates TCI. You can think of this as sort of a negative loading dose, right? If you want to decrease the infusion, you should stop it briefly before you turn it back on, if you really want the levels to drop quickly. Now, I want to just mention quickly something I think is really important, because one of the things we've worried about as an anesthesia community is the GI nurse or the GI doc with a 20 cc syringe of Propofol in their hand. I mean, that's a scary thing to think about, isn't it? Well, what's scary about that mostly is the bolus capacity, the bolus function, because bolus has changed physiology very rapidly. And I want to just illustrate this with a little drawing. So this is basically a little lesson on the control of breathing that anesthesiologists are all very familiar with. So here's the arterial partial pressure of carbon dioxide, and here's the minute ventilation. And we normally have this very steep relationship. As PCO2 rises above normal, ventilation just goes through the roof. And when we get sedated, three things happen. You shift to the right, you flatten, and this hockey stick is gone. And that means there's a CO2 below which people won't breathe, right? There's an apneic threshold. Now, when you bolus, you get that kind of relationship. If you achieve the same drug level, but you do it more slowly with infusion, you can get the same level of sedation, but not as much perturbation of ventilation. So an infusion, because it comes on slower, it's better tolerated, and you're less likely to be apneic. So this is, I think, one of the key components of the system, that it doesn't give boluses. The loading dose, for example, is not injected over 3 seconds, it's injected over 3 minutes. That means that it's a slower system. Anesthesiologists might be impatient with it, but it's less likely to change things dramatically. And in biology, the rate of change matters. The first derivative matters. Okay, let's turn to the pivotal trial, and I think I've got about 10 minutes or so to go to wrap up. So again, this was the pivotal trial. The CAPS system was approved on a PMA basis, a pre-market approval basis, which is a much more difficult task than a 510K approval, as you know. And that's because it's a first in class, and so it's scrutinized much more heavily from a regulatory perspective. So this was a randomized, non-blinded study comparing CAPS with fentanyl, so propofol and fentanyl delivered by the system, compared to current standard of care, which was midazolam opioid with O2 and whatever the monitoring standards were at the facility. So this truly was meant to sort of be a comparison of the new technology with what's currently being done. This was multi-center with 1,000 subjects undergoing elective endoscopy procedures, about 3/4 of which were colonoscopies, and the remainder were upper GI endoscopy procedures. Now, the primary endpoint was something called the AUC DSAT, and this is something that you might not be familiar with, so I'm going to take you through it in a moment. I put this up just to show you that if you want to read the peer-reviewed article that appeared in Gastrointestinal Endoscopy 2 years ago, and the first author is Pambienko, Dan Pambienko, who's associated with University of Virginia in Charlottesville. So, and it was entitled Computer-Assisted Personalized Sedation for Upper Endoscopy and Colonoscopy, a comparative multi-center randomized study. Now, it's important to note the guiding principles of the trial. The first assumption was that, look, propofol is an efficacious sedative. We all know that. There was no controversy about that. So this was not really an efficacy trial per se. Safety was the main concern. And the concern with safety is that you're going to kill people or make people brain dead, give them brain injuries, or make them have to go into the hospital, into an ICU, and so on. And so it was widely agreed that hypoxia is the mechanism of injury, and the Anesthesia Advisory Board, after considering lots of different possible surrogates, decided to go with the AUC DSAT, the area under the desaturation curve, as the best surrogate for hypoxic injury. You can't do a trial where hypoxic injuries are actually the outcome measure because it's just not feasible. They're so rare. So you have to come up with a surrogate that you believe in. And this was the surrogate that was agreed upon. Now, there are all kinds of ways you can look at hypoxemia using the pulse oximeter. You can say, well, here's an event and here's an event. These two subjects, if you were just counting desaturations, would be the same. And yet we all look at that and we say, well, this one's worse than that one. So event count versus the nadir are a consideration. Another consideration is the duration. So here's a desaturation to the same level, but I think we'd all agree this one is worse than that one, right? Because of the duration of the exposure. Not only does the rate of change matter in biology, but the area under the curve matters. The duration of an exposure matters. So this AUC DSAT is the area under the pulse oximeter curve that's under a 90% saturation. And so in this particular case, these two areas would constitute the AUC DSAT for that patient. So that was the primary outcome measure for the study. Now this is the main this was the main efficacy, or this was the main outcome signal for the trial. So this is a depiction of all subjects with an AUC DSAT that was greater than 0. So many subjects didn't desaturate during the case. But in the current standard group, 83 did, and in the CAPS group, 38 did. And this turned out to be a very, very substantially significant difference in terms of the area under the desaturation curve. So these are all the subjects ranked. These subjects have the highest area, and then these subjects have the lowest area. There are other ways to look at this in tabular form, but this is sort of the best visual representation of that primary outcome measure. Now, this is also something I think is very important for anesthesiologists to see, because we have a sense for what a dose of propofol means, especially in the US, since we don't do it by TCI. We have a sense of what should sedation doses be versus what general anesthesia doses are. And this is a distribution of the procedure maintenance rate, and this is the number of subjects that had a given rate, and the mean rate was 50 mics per kilo per minute. That's an important finding, because it shows you that, in fact, Sedasis is delivering propofol at a rate that is in the inspected range for sedation, and in fact is compliant with the propofol label in terms of the doses for max sedation, which was an addendum to the propofol label that occurred after the original approval. There were a number of secondary endpoints: endoscopist satisfaction, patient satisfaction, the time to recover from sedation, and the duration of deep sedation and general anesthesia. So let me take you through a visual representation of each one of these as we finish up our discussion about the pivotal trial. So this is the distribution of all the sedation scores from the study, and I don't have this in color, but this is from the pivotal trial. So the gray bars are the CAPS group, and the darker bars are the benzo-opioid group, and this is the percent of the MOAS scores. So the MOAS scores is a validated sedation score that most people in this room are quite familiar with. And anyway, scores of 2 and above are moderate sedation, and you can see that the vast majority of these scores were 2 and above. There were some very rare episodes, the boxes are almost too small to see, of deep sedation and general anesthesia. Now this is really quite interesting to me. There were episodes of desaturation in the deep sedation and general anesthesia patients, but not in the CAPS group, only in the current standard of care group. And that tells you that sedation is a correlate and a reasonable marker to follow in terms of the risk of hypoxemia and desaturation. But it's not necessarily it's not necessarily true that if you have deep sedation you will desaturate. And the CAP system didn't have any desaturation episodes during these deeper than intended sedation episodes. So basically what you can conclude from this, I think, is that propofol via CAPS targets and achieves moderate sedation. To my mind, that's very critical as an anesthesia community, because I strongly believe that deep sedation is the purview of anesthesiologists and people with special training and skills. And when a practitioner is doing deep sedation, that's when they're doing something that at any second can require sort of life-saving maneuvers. And it's a step well beyond moderate sedation. And so I think for this technology to fly in the hands of non-anesthesiologists, it really had to target moderate sedation and not deep sedation. This is a representation of the physician satisfaction. The endoscopists over the years have validated what's called the clinician's satisfaction with sedation instrument, and this shows the distribution of those scores. And basically what you see is that the physicians really like the Propofol better, interestingly enough. This is well known, by the way, in the GI literature. That's why they've moved to it. They like Propofol better for a variety of reasons, and I think chief among them is that the patients recover faster. So in many endoscopy units, it's the recovery room that kind of is the problem, the rate-limiting step in their operation. This is the patient satisfaction instrument, so the patient satisfaction with sedation instrument, and these were essentially the same. So, you know, if the patient's sort of sedated and unaware of what's going on and sort of knocked out, so to speak, they tend to be pretty happy. By the way, this was an important finding because I think there are many that believe, well, if you're not getting deep sedation, neither the GIs nor the patients want to undergo the procedure. And in fact, these are very high levels of satisfaction by the patients. So that means that it's sort of dispelled the myth that you have to have deep sedation to undergo endoscopy, and that the GI docs insist upon deep sedation, although that may well be true that in many places they do insist on deep sedation. This is a representation of the recovery time. So this is the time when the patients got back to a level of alertness as defined by the MOAS score, of the alertness score. And this is another outcome in which the CAP system was considerably better than current standard of care. And I think this is really the attraction. The rate-limiting step in an endoscopy operation is people piling up in the recovery room. And with Propofol, these people recovered really minutes after the procedure and are able to go home fairly soon. And that's something that improves the efficiency of the endoscopy units quite a bit. Okay, so what are the key findings then of the pivotal trial as we wrap things up? CAPS is superior to current standard of care in terms of AUC-DSAT. That was the primary outcome variable of the study. There's a very low incidence of deep sedation, that is, CAPS produces moderate sedation. And these instances of deep sedation typically lasted not much longer than the assessment interval, 30 seconds or so. And so the deeper than intended sedation periods were typically brief. There's very high user satisfaction for both for the clinicians, rather, the endoscopists. The typical dosage range was 50 to 75 micrograms per kilo per minute, which is what we expect for sedation procedures. And then finally, the recovery was rapid. So let's just finish then by thinking a little bit about the implications of this for our discipline. So CAPS may present opportunities for the anesthesiology community. And I've had the opportunity to share my views with some of the leadership of various anesthesia societies and entities. I want to just sort of get you thinking about, what are the questions? We don't know whether this is going to be disruptive, in part because you don't know how the marketplace is going to receive it. But there are just all kinds of questions relating to how is the technology going to be viewed. The regulatory bodies have sort of already weighed in, but there are other countries yet to come. The payers have to respond to this. The accreditation bodies have to respond to this. And they're very keen on scrutinizing sedation practice in the U.S. The gastroenterology community has to respond, and again, they're not all aligned. They're divided somewhat over this. The anesthesiology community needs to respond. Other device companies, now there's the opportunity for a 510K approval process, right? Although there would be some patent infringement issues that would have to be dealt with. And then what about the patients? The patients, of course, are the primary drivers. If your endoscopy unit gets calls, well, do you have that new machine? Because I'm not going to come there if you don't. Then that will drive things significantly. If that doesn't happen, then that's not a big driver. So I think these are the opportunities for anesthesiology. First of all, there's the political opportunity. I think this is very important for us. This gives the anesthesia community an opportunity to define the boundaries of appropriate propofol use. It gives us a chance to say, propofol is a good drug. It should be more widely available, but we can't have people doing deep sedation and general anesthesia out in the hinterlands with this. It's too dangerous. So this technology allows us to carve out an appropriate use where we can say, this is the line between moderate sedation and deep sedation with regard to propofol, and this machine ties your hands so that you can't cross it. And we will continue to own and supervise and regulate and lead deep sedation and general anesthesia practice. So that's the first opportunity. The second opportunity is a public relations opportunity. I want to look you in the eye and tell you this very sincerely. I am very, very proud to be part of the specialty that developed the best practices that have been inculcated into this technology. All of this comes from anesthesiology. The drugs, the kinetic concepts, the monitoring technologies, the clinical techniques, we have provided the leadership, we have established the best practices, and quite honestly, I believe it's our duty to bring these to the rest of medicine in a measured and appropriate way. And I think this is a great public relations opportunity. And if I were the ASA, I'd be waving a flag. Look what we did. And in fact, it was an anesthesia advisory board that played the key role in the design of the technology. Now that's a tough thing to do when your income is threatened. And so I don't think there'll be a lot of people who do GI endoscopy as anesthesiologists, and that constitutes a big part of their practice. They may not be as proud as I am. And I understand that, and that's a practical reality. But we should be proud, and we should lead the way, and this is a public relations opportunity. And then the final is a leadership opportunity. We have the opportunity as anesthesiologists to reassert ourselves locally and say, we're going to help shepherd this technology and guide the process. Maybe we'll be more involved in training. Maybe we'll be more involved in sedation committees and credentialing and privileging. It gives us a chance to ratchet up sedation practice standards and lead the way. And so these three opportunities, political and public relations and leadership opportunities, I think are things we should embrace. So I thank you very much for the opportunity to summarize the technology, and I think I've stayed within my time limit, even though we started a little late. And we'll look forward to questions at the end of the session. Thank you very much.